Hey guys, welcome back to SHARC Doc Talk. I have to go slow with that one because I'll mess it up. Over here we got Dr. J. Over here we got Dr. Dionson. Got it right. Right in front of us we got some momentous products that we love to use. Check us out online if you want to see more about that. Okay, we're going to dive right into part 2 of what we did last week, I believe it was, about youth athletics. We're going to jump into Justin's or Dr. J's case. He's going to give us a little background and dive on in. So here we go.
All right, so my patient was a 15-year-old female, presents with inner knee pain. So
By inner, he means like the inside of the knee next to the other knee. So medial side.
yes, very scientific. Thanks for the clarification.
Had to.
Yeah. Okay, so when I saw her, she came in October, and the pain had been inner knee since March. And since it started, it just kind of stayed consistent. Sometimes it would feel better, sometimes it would feel worse. It usually had to do with the level of activity, that it would increase her pain, or if she was not playing as much, the pain would kind of calm down. She tried rest and ice, and that would help, but the pain kept coming back. And anything that she did on the court, whether it was jumping, running, cutting, any direction, it would bug her knee. She described the pain as sharp, and when we were talking about rating your pain last time, where we almost felt like, or in my experience, it was almost like a cry for help, where they would say, like on a scale of 1 to 10, how's your pain?
Right.
And our fingers kind of be hovering over the numbers.
And just to recap for everybody who may not have seen the first one, when we're talking about youth athletics, there's always caveats to a child. Especially as it pertains to injury, and especially as it pertains to the passion for sport versus how bad the injury is in their mind, and if they actually want to be playing or not, and so forth. So we went down this whole rabbit hole, I guess you can call it, based on all these things. A level of pain for us as doctors is a simple way to say, if 10 is you going to the hospital and 0 is no pain at all, where do you rate your pain so that we can get an idea mentally of what's going on or kind of how it feels? It's us trying to understand your pain. What he's referring to is we have the psychological side where I had a client years ago where I got the gist that the kid did not want to play football anymore because he had an excessive amount of pain, but he didn't present that way. Mm-hmm. So they didn't walk in the office like they were dying or anything like that. They're not acting like it. They're not screaming out an orthopedic test. They're just kind of like, yeah, it's a 9, and very casual. And all of us at this table have been in a 9. That's not how we acted. No. It's not that we're babies, I swear, but it's just you have this presentation of a serious pain versus a non-presentation, but you got the interpretation of it's worse than it is. So that's just a quick catch up, but that's where we are with this one.
Exactly. So with pain that comes and goes, I don't know about you guys, but if I were to guess, like pain that comes and goes and it's like kind of pain with activity, I would say probably like a 3 or a 4. That's what I would be expecting.
Yeah. Pretty common. 3 to 5. Yeah. 3 to 5.
Like
pretty
3,
common.
4, 3 to 5. So she said that when it started, it was a 6, and when at its worst, it was a 7 or an 8 out of 10. Oh, wow. Which is, I mean, that's pretty substantial to us, right?
Yes. Yes.
Because 7 or 8 is like, okay, there might be something actually structurally wrong, and so that's something that we keep in the back of our mind while we're our history. And
I'm so sorry.
Yeah, go for it.
Because that too, the reason that why he says that is kids have a knack for also underplaying their pain. So they may have a knee pain, but they're afraid if they tell somebody, they'll take me out of the game, can't play. So they don't want to say anything, so they're going to minimize their pain. So we have 2 extremes. You have the minimization of it all and the exaggeration of it all. So go ahead. That's what you put in the memory bank back there just in case, like, is there something structurally wrong the kid's ignoring?
For
Got
sure.
it. Yeah, good.
Yeah, so some more...
Coffee morning.
Yes. So more specific questions about the knee. She said that she explained that walking upstairs hurts, but not going downstairs. Going downstairs is fine. She feels like the knee gives away. She denies any popping or clicking in the knee. And then in her workouts, when she's doing ladders, like lateral, like an icky shuffle, for example.
I hope the crowd out there knows who that is.
Should I even try to explain what an icky shuffle is?
I don't know if you can.
With words. It's
I'll
hard.
just plug it in right here.
Yeah,
right.
Put it up on the video and you can see it. That's so great
going
idea.
ladders left to right, but not right to left, would bug her left knee.
Yeah.
I'm still stuck on the shuffle.
Yeah, I know.
Yeah, right.
Can't unsee that.
So, her goal for treatment was she wants to play without pain, because who doesn't? And she wants to be pain-free by January. Her practice schedule. So she has school every day, and so she'll have practice, if not every day, it's at least every other day. So she went from court, and then at this time, she was transitioning into beach volleyball as well. Okay. And then I saw her in October. She was explaining that in November she would be starting club volleyball, and that'd be twice a week. So she has school, she has beach volleyball, and she also has club volleyball.
Okay, let's do a quick before we go any deeper. Let's do some quick thoughts from the docs here. So let's jump. David, what are your thoughts?
That's a lot of playtime, a lot of practice, without proper rest, really. And plus, she's a student too, right? So she
15?
15.
Yeah,
Yep.
so
sophomore.
She also has to study. So where is nutrition? Where's the rest coming in?
Yep.
That's first thoughts. Yeah, my initial thoughts, same thing, is we're along hydration, sleep quality. How is she with the stress response? Like, kids have stress. I watch my kids do it. They just don't know how to identify it usually, even at 15. So I'd be like, okay, let's see how her stress response is. And then you got to, I mean, it's funny when you start talking about these things and you talk about schedule. My first thought is we have to add 30 minutes of something to her each day. Mm-hmm. Rehab, movement, something where her body can get stronger while she gets out of this. And then you look at her schedule and you're like, where do you want to plant that? Yep. 4:30 in the morning? Sure. I see a 15-year-old getting up. Absolutely. That makes a lot of sense. So yeah, it's a very
literally
interesting schedule. Yeah.
She said if she's not at school, she's not at practice, she sleeps.
Again, I totally get it.
Yeah.
So
same.
This is why we do this podcast specifically, why it's probably going to be 3 parts. The emphasis for kids, and they're kids, even though they think they're adults already at 15, and that's just how it is, but they're children who are still developing, still growing, still everything, who now are suffering an injury, having pain. It's inhibiting their playtime, inhibiting their ability to play, plus other aspects of life. And we have to sometimes sit back, like with her, and I'm curious what I only cut you off to do this to see where you went with it, because it's kind of fun to see everybody out there watching, like, Dr. Deonson does one thing, I'm going to do another thing. What did Dr. J do? And then we'll kind of commiserate on that whole thing. Yeah. But with those kids, you really have to, as a parent and as a coach, be mindful of all of those components. Mm-hmm. Because kids are not. They're almost on autopilot, especially if you're mid-season, mid-school year. You cut in somewhere in March, now, February. Schedule set. Monday morning they get up at. Monday night they go bed at. Tuesday morning they get up at. They go to practice at. So it's just a regimen. So they're not going to notice slowing down, fatigue, not able to focus today. They're not going to notice that the same way because you're just going on autopilot. Yeah. So, all right. So what did you do?
Yeah. So on exam, so I did a full body kind of range of motion just to partly clear the spine. Just any spinal involvement, because with chiropractors, let's clear the spine first, then let's move outside. So lumbar spine, flexion extension was fine, but rotation both ways was limited, but it was not painful.
You said that was rotation?
Rotation. Her squat, she had knee cave on that, especially on that left side. And she explained that she was feeling stiff getting down into the squat.
Did she mention where limitation on that was?
I didn't note it down. Yeah.
No worries.
So forward lunge on the left. She had pain not going down into the forward lunge, but pushing herself back out of the lunge.
And when you say pain, that's knee pain?
The chief complaint. Yeah, the inner knee pain. As far as orthopedic testing, I wanted to check the hip because at that point I had been almost, I guess, testing a theory of either low back pain with hip range of motion or knee pain, ankle pain, and looking at the hip and having that be kind of like my basis, and then I kind of go out from there.
All right, we do a quick plug. What he's doing, for those out there, is he's putting together a piece-by-piece systematic understanding of how her body moves. And what that means is you need to understand how the system of the ankle, the knee, the hip, how they work individually, which is basic orthopedic tests and range of motion, things like that. Then you want to plug in how do they work with everybody else. So when you see somebody he was talking about with the knee dives in a little bit, so when they squat down, their knees cave in, he's seeing a breakdown somewhere in the hip, the core, the hamstrings, the calf, somewhere in that system, she's getting a breakdown. We don't know where. Now let's extrapolate this because I'm a volleyball player. I have to say more. That's
Sure,
just the way it is. Got to talk more. I love volleyball. When you think about the jump, it's a squat. Not the same depth, but still a squat. Generating power, ground reactive forces, up you go. Where injuries happen in volleyball, much like basketball, it's not the jump that gets you. It's landing.
Way down.
And if you can imagine in your mind, her knees, when she lands, dives in like this, the stress is going to go to her knees because the rest of her body is not absorbing that energy as she comes out of the air. Now, if she's gifted with vertical at all, it's even worse. So that's why Dr. J is kind of putting it together like check the ankle, check the knee, check the spine, check the hip, check the pieces. Now let's put them together in some movement patterns and let's see where the flaws really are in movement patterns as well. So
I got one question about that lunge you did.
Yeah.
You said pain going into the lunge?
Coming out of it.
Coming out of it. And then with that, when she got into the lunge, where was her knee tracking? Over? Was it?
It was
stable?
a little
wobbly.
medial. Yeah.
Medial?
Yeah. Like it generally unstable.
What about as compared to the toes? Is it going over the toes or is it?
It was more going over the big toe.
Okay.
Yeah.
So just again, clarify for everybody out there and why, I guess I clarify because this is why we talk about these things. So you as clients out there, or people watching and say, hey, I'm going to see what these knuckleheads are talking about. And you see us talk and we go through these positions and whatever we do and we're explaining why. It's so you yourself can see in your child or your loved ones or family, whoever, if you see him walking or doing something, you can say, oh, I think there's a reason you have knee pain because you're doing these things. When she hits her foot to the floor and her knee shakes a little bit on a lunge, that's the body's instability system. So she's stability system that's unstable. So that means that her foot proprioceptive stuff is kicking back to her brain, which is kicking back to the hip, and the hip is trying to stabilize her, but she's shaking because the input's coming slow because it's not an efficient system. So our notes are, it dives. It's not like, it dive in, you have a weak butt. It's not just that. There's other pieces that go with that. It's just they all kind of come together. So we're trying to literally pick apart why in the world does this little girl's knee hurt? And it can't just be, unless she's injured, torn a meniscus, torn an MCL, whatever. But she's not. She's just been overusing it, what have you. So continue. But that's why that's important.
Yeah. So range of motion or passive range of motion of the hip. Flexion was fine, not painful. Internal, external rotation. The right side generally moved better than the left side. So left side is the side of chief complaint. That left hip is really stiff. I didn't check or I didn't write down exact degrees of internal and external rotation. But
How dare you?
What's that?
How dare you?
What is
I know,
wrong
right?
with you? I trained you better than this.
Yeah, straight up. The school would hunt me down and
They may still. They might
they
watch this and be
they're
like,
gonna
we
see
got
this
to.
and be like, are you
Can't happen.
kidding me?
So I do have one question with the lunge, and this is a nuance. Mind you guys out there,
Yeah.
2 years in, 2.5 years in, 2 years in, 20 years in, my brain just works differently. So I'm just asking this question. I don't know if you did it or not.
Yeah.
Did you see a discrepancy from the left lunge to the right lunge? Like, was there a difference in the way that she
where I was gonna go.
came in, came out? Yeah, because I trained
Yeah.
you well. You listened.
Yeah, I mean the right. Yeah, so the right.
just
lunge,
kidding, by the way,
I didn't
Dr. J.
have any. I didn't have any notes for the right lunge.
That's cool. Okay.
So basically, I felt like it was generally strong and.
Okay. Yeah. No worries. No worries.
Yeah.
Great.
No breakdown. Okay, so left hip, internal external rotation, very stiff. Then I go to check the knee. So she has. I rated a +2 tenderness to palpation over the medial femoral condyle. So that's just above the knee, not on your shin bone, but on your upper leg bone, on the femur.
That'd be basically your thigh.
Basically
So
the thigh.
closer to the thigh, top of the knee, if you will, where your little patella, your bone that sits on the knee there, just above that.
And then I did a McMurray's test. So we're testing the integrity of the ligaments and also the meniscus on both sides.
How was that menisci?
So she had painful medial aspect of the joint line.
Interesting.
So,
You know, a
it
weird
is
thought
interesting,
popped in
yeah.
my head right now. It's a bone bruise. So I'm just thinking where you're palpating and going. It's like if she's repetitively jumping, which position?
I didn't write that down. But she's taller, so I don't know if that helps you.
Okay. We love Dr. J. He's amazing. These are things again, like we have the luxury of sitting down and listening to him speak. We're sitting here taking notes as if this is a new patient for us. So now we can ask questions because we're getting it. Yeah. Real time. You're focused on other things. So the bone bruise, when she lands that way, regardless of her position, middle, outside, opposite, whatever, even back row, there's still the landing and falling and getting back up and stuff. That bone bruise is something that could be very possible.
100%.
Yeah. And that would trigger. So the caveat with doing an orthopedic test is orthopedic tests are only one piece to our puzzle of figuring you out. That's why we do so much assessment stuff. So if she had a bone bruise, it's going to mimic a meniscal injury or painfulness, an MCL sprain or pull. It's going to mimic that because that's where all those attachment points are and locations are. So proximity can give you that false positive, which is why you dig a little deeper.
Question about McMurray. Do you have any grinding with that too, or any catching?
No.
Okay. Yeah.
Yeah, which is, again, that's why I probably lean more, again, towards
I'd agree.
towards a bone bruise, a bone stress response, that kind of stuff, yeah. So the initial diagnosis was probably like a MCL sprain. Maybe there's something with the meniscus there.
For sure.
But either way, the main problem here was that I felt was I got to figure out how to gain more motion in the hip, and then I got to rehab her in that new range of motion so that she can receive herself.
How is total flexion of the knee, like heel to butt?
I didn't check that.
Okay. I'm not going to ask any more questions about that.
I'll ask a leading question here. All right, so we've been talking about
questions.
knee this entire time, right? And then your thought process was to go toward the hip. I know as patients and clients, when they come in, when they get really confused about why we're going toward the hip rather than just the knee.
Or the calf.
Or the
ankle.
calf.
Yeah.
Can you kind of, for both of you guys, can you kind of explain why are we doing that here?
And we'll be back. All right, welcome back. We're going to continue on our path down the road here. Dr. J, go ahead.
All right. So for treatment, treatment goals, right? I'm trying to gain more motion in the hip, and then I'm going to settle down the muscles that are they're not functioning correctly. So what we do with the active release technique is we're trying to restore normal function to the muscle so it can actually do what it's supposed to do, and it's not getting put in a position to do another muscle's job.
And so, of course, I got to chime in on this one.
Yeah, sure.
Basically, what it means for all of you out there is, while we're looking at your body and the way it moves, or correctly, incorrectly, dysfunctionally, compensatorily, whatever, what we're trying to do is figure out not only where the systems are breaking down, how we're going to fix all that, but we're going to treat the tissue too. Mm-hmm. And so, the one thing we use active release technique is we're actually trying to create a healthier tissue, because if you have scarring in there and scar tissue and whatever built up in there, plus a compensation pattern, plus other muscles that are overactive, all of those pieces, you can't just do some basic rehab stuff or stretch and correct the pattern. It just doesn't work that way. So you got to break down the scar tissue, whatever limiting problems the tissue has, so it can do its job. Then you implement what he's about to get into, which is then how to do your job, and then you connect it to the rest of the body. And that's kind of what he's going to jump into now. And I just want to note real quick, one of the luxuries Justin had was being able to see her move, which is why when we ask questions, it's because we didn't get to see her. And then he was telling us on the break that he actually has a video, which we're really excited to see. But when she lands, her knees kind of hit the ground and shake a little bit, which kind of tells us what we need to know. So, so that's what he's discussing right now.
Yeah, so as far as soft tissue, adductors, hamstrings, they are both muscles that cross the knee. And so I started there. And
inner thigh muscles.
And inner thigh muscles, yes. So adductors, hamstrings, and then the inner quad muscle, vastus medialis.
Obliquus.
VMO, obliquus.
It's the teardrop.
The teardrop in the knee.
Teardrop.
Google soccer player and look at their knees, and you'll see the teardrop.
Or cyclists.
Or
professional
Saquon Barkley.
Oh,
Saquon
that's not
Barkley.
fair.
Yeah.
That's not fair. That's too much.
And then I also worked on the glute.
Nice.
And then I also, before I did soft tissue, this was something I never thought I would use in practice when I learned it in school.
Ooh.
But I used post-isometric relaxation.
Oh, PIR.
Yeah, PIR and reciprocal inhibition.
Nice.
So basically what that does is I'm using breath and a slight contraction of the muscle groups that are supposed to be doing internal and external rotation in order to let the body kind of relax and get that capsule to relax, and you gain more motion. Then I dove in, did the muscle work, and then we went into the rehab.
And a little background for everybody out there. The biggest thing is your body will not let us do what we want to do with it unless the brain and the nervous system are ready to allow it to happen.
Yeah.
So for a quick example, you tear your ACL, your quad muscles are inhibited. They don't want to contract because it's trying to protect your knee. That's what the body does. It protects you from hurting yourself for the most part. Of course, we as humans proceed to go ahead and push through that wall, but that's kind of what he's talking about.
And then as far as rehab, so we have more motion in the hips. We've gotten the pain to calm down, which is important. And so I started out her with glute ham bridges and then clamshells. And then on week 2, I introduced single leg wall RDL, which I
love that one.
Yeah, that's one that I think we all love.
Now remind me, I figured out something too.
Oh yeah.
A way to we went over that yesterday a little bit. Yeah, remind me after this is all over.
Okay,
I'll show you.
perfect.
Yeah.
So yeah, and then after that, let's see, how many visits did it take? So 1, 2. On her 3rd visit, so initially I saw her about twice a week. So after about 2.5 weeks, she finally had relief. She was able to go through a volleyball practice, felt like she didn't need to wear the brace anymore, and she was running, jumping, cutting, doing everything.
That's good.
With anything, like if anything at all, like minimal, like 1 out of 10 pain.
Okay.
Noticeable, but not stopping you.
Exactly.
Well, sometimes that even just comes with sport, right?
Yeah.
You're going to have some pain with sport.
Well, when I just found something, we got her to calm down, and then she came back in 1 week and was like, yeah, I ran a mile, and that started to bug me. And I'm like, great. Why are we having a volleyball player arbitrarily run?
That jumps into
1
something else I'll
mile?
get into later because I love
Yeah.
volleyball, but there's some history to that. And just for everybody out there, good note for you guys out there. When you have a time delayed onset of pain, meaning that my next question would have been for her in real time if I was there, how far into the run? I'm assuming it's 800 meters, 800 meters, somewhere in there.
laps.
Half. That's where the pain's going to start. That's only because Dr. J is 3 weeks into a program that probably takes 6 weeks to complete and probably another 3 months for her to really gain strength with which she could run a mile without falling back into her compensation patterns. So she made it a good 800. That's impressive. That's pretty good in a few weeks. And then I'm sure things started to break down a little bit. That was just too much for her trained body to handle. She wasn't trained for that just yet. And then we'll talk about the endurance athlete for volleyball later.
Yeah.
Great.
And then like a couple weeks after, she had a couple flare-ups, nothing too bad. I like to explain to patients that that's a normal progression. Like you're going to have flare-ups. There's going to be things that are going to irritate it.
Absolutely.
And that's a natural progression, and to not get frustrated and
sure.
kind of like really playing in more to that psychological piece. Like it's going to happen. You're an active individual. You're going to have flare-ups, and that's okay. That's a natural progression. As long as we're doing the rehab exercises, then we're still on the right track. And she stuck with the program. And so she came in October 4th, and by 4 weeks later, she was good. She never complained about knee pain again.
That's so good.
That's great.
Yeah.
Now the hard part is you got to chime out to her about 2-3 weeks after treatments are all over and done and make sure she's doing her rehab stuff still.
Yeah.
Most people out there, the biggest mistake they'll make is as soon as they feel good, they stop. And mind you, all 3 of us are guilty of it. We stop the things that are helping us feel good, which make no sense, but that's just human nature.
Yeah.
Yeah. Once we feel good, our attention is no longer called toward that area, so we don't think about it. Yeah. And we go back and do it again.
Yep. Absolutely.
All right. Well, that was good. I like that. Obviously, because volleyball for me, I love that piece. Any thoughts on that, David, or anything yet?
Yeah. I think if I was coming in as a patient, right, I'm dealing with, how long was she dealing with this before she saw you?
About 6 months. So she came in October. She had been dealing with it since March.
Yeah. One thing that I want to point out to the audience here is that if you're having a chronic type of issue, 6 months, right, without a true mechanism of injury,
Meaning a trauma.
Yeah, no trauma.
Broken
here.
leg, twisted ankle, something like that.
Yeah. Oftentimes, we may not just look at just the knee. Hence why some of his exercises were bridges,
Hip and core bracing,
clamps.
yep.
Yep,
Yeah,
hip and
hips
core
and
bracing.
core.
The reason why is because if it's a longer term injury, just like that, it's a movement pattern type of thing. And how do you get to those issues, right? Rather than, oh, someone hit me and landed on me, right?
Yeah.
So we have to address it that way. Hence why if he's treating glute, that's why we're going down that rabbit hole here.
Yeah. So, I mean, I'll elaborate a little on this one for you guys. Basically, what they're all saying is when you have a chronic injury or a chronic problem, so I hate to say injury because I don't know that she was injured. We'll say a chronic problem, right? Pain. What happens is basically this. You sprain your ankle, you're going to limp, right? You're going to limp until the pain's gone, but guess what? You still limp. So if we took video of you on a machine that tracks body weight distribution as you're moving, like a treadmill or something like that, but side by side, you'll see a distribution of weight away from the sprained ankle side. Because your body doesn't just go back to normal, quote unquote, because there's no pain. Pain's just a symptom, right? And you can't chase that pain. You have to figure out why you're having the pain, especially if there's no traumatic incident. So what happens is over 6 months, as an athlete goes, athletes already have bad movement patterns by the nature of sport. But over 6 months now, she's compensated God knows how many ways to try to avoid the pain, try to make sure, probably landing on one leg so she doesn't hurt that other knee, which might be why, we have to check the right hip would be an interesting endeavor as well to see what that looks like. But that thing is he's trying to make her an equal balanced human again. I can live in the world, I can be a human, I can move like a human and be normal, and then also help her stay stronger for sport. So that's what Dr. David was talking about. We spend half of our time in our minds figuring out how to normalize this person as well as get rid of their pain and put them back on the court without pain in their sport. So there's a lot going on in our heads when we're working with you. It also explains why we need that time with you.
Yep.
I mean, it's one of those things. I've been doing this a long time. I started out shorter visits and they just kept getting longer and longer because I need the time.
Yeah.
Especially when patients come in, I can't tell you when patients come in and, well, my back's feeling pretty good, but now my shoulder's bugging me, or my shoulders always bug me, and we never talked about that. I'm like, well, why didn't you mention that? Like, I just didn't think about it. I'm like, okay. And all of a sudden, now we got a right low back, and we got a left shoulder, and we got a right ankle, and you're like, oh, there's a problem here. So this is why we spend all this time with these patients and go through these thorough assessments to make sure we actually understand not just, what's going on with you right now, but kind of like your path, your road to us. Like, how did you get here?
Yeah.
How did you get to this point? So great job.
Thank you.
Yeah, I mean, great job. There's a couple things I'd have done differently, but whatever.
That just means
Just kidding.
That just means we're different docs.
Yeah,
Well-
we shouldn't be carbon copies of each other.
No. The premise of our philosophy here is we are patient-centered, which just simply means we're doing everything we can for the patient. It's not for pocketbooks or this or that or taking pictures or photos or social media stuff. It's more like we just want you to get better because our egos are kind of tied up in that. And then from there, it's like you got 3 different doctors here. You give me 3 orthopedic surgeons in here. He paints that same story. You're going to get a blast from all different angles, from experiences and book knowledge and things that are remembered. And it's just how the mind works. And as the doctor goes, you saw us taking notes as he was talking because we're interested. We're curious. And in my head, I'm like, what would I do? How would I do it? Would I do this differently or that differently? And whatever. That's the beauty of it all. So the intention's always going to be for your benefit, you getting better faster, getting back to your sport. And for us, we know, especially in athletes, if you can't play your sport, you're not a happy person, which means everybody around you is not happy. And so our goal, too, is to make everybody around you happy by making you happy. So that's really what we're after. So well said.
Yeah, in terms of like the active population, oftentimes the phrase that gets used is, oh, this is an overuse injury, which true, I kind of understand that sentiment. But really where my brain goes, at least in this group here, is active people require active solutions.
I like
So
that.
they're underprepared for something.
Yep.
So we have to train that something to do something else.
Yep.
So that tissue could be overused, but something else is underprepared.
And you could also think about it this way. Instead of using the word overuse,
Yeah.
I put in misuse. So that means you're using your body the wrong way. And that's not an intellectual, I'm doing it on purpose thing. That's just a neurological, I have to do what you're telling me to do. I want to run a mile. Well, I'm going to try, but my body can only really handle 800 meters. And then I kind of go back to my lack of efficiency movement patterns, which got me here. And then the knee starts bugging her. So, wow. Yeah, that was fun. All right.
Yeah.
Anything else finish up with?
I don't know. I think you'll love this. We started doing BFR towards the tail end of it.
That's fun.
Oh, yeah.
Blood flow restriction. If you don't know
that was
it,
a good one.
yeah, reach out to us. We'll get us a comment or something like that. We could actually post a video on a routine as well.
Yeah.
That would be, I don't know, visuals would, yeah, that'd be good.
I mean, if you guys want to come in for like a mini session of it,
You're welcome.
You're
yeah,
more than
give us a
welcome.
holler. We'd love to.
Yeah.
Go ahead. So
But
BFR,
yeah, I mean, as far as BFR, let me find like yeah. Well, and she started to deal with a little bit of a shoulder thing at the tail end. Nothing major. It was just like just general soreness.
You know what's funny about that? And I'm not lying. I can draw from volleyball. We got her hips working. We got her lower body creating more power. And guess what her upper body now has to learn to do? Because now her hips open. So in volleyball, think of it like a golf swing. If I'm taking that backswing in volleyball and I'm going to wind up and bring my shoulder back, my arching, I'm now creating more torque. Now that her hips are more open, more powerful, more torque. Well, the thing that slows down the shoulder after the hit is not the legs. So it's the shoulder muscles, sits muscles, your rotator cuff stuff. So now, right, that's where we get that integration of like, you know what? I'm going to reach out there in a couple weeks, check on that shoulder. And if we're not getting there, we need to connect those dots.
Yeah.
Right? That's kind of what we need to do. But it's very funny in sport. I can't tell you how many people come in out of pain, moving better, stronger. They're like, thanks, doc, see you later. And I'm like, okay, don't disappear. Like, we're not done. Come in 2 weeks later. You know what? My neck's a little tweaky now. It's because everything else is moving better. So, but they're not connected, right? We haven't connected all those dots yet.
Yeah.
So, yeah, that's a very funny. In volleyball, that was so common.
For
So
sure.
common, yeah.
Yeah.
Baseball,
so,
too, I would imagine. I mean, any overhead sport like that.
Oh, 100%.
Yeah.
Yeah.
Any
You
rotational
you
sport,
find your
yeah,
hips, and then all of a
rotational.
sudden you start throwing hard. You're like, oh, now I'm a little more sore than I usually am. Like,
Yeah.
why is that?
And I'll answer that question when we come back.
Kind of. That's the wrong button, but here we go.
That was perfect.
We're back. And I hope you love the sound effect. Please leave that in. I thought that was great. I did that purposely just to give you a water break here real quick. But okay. So the why on that whole thing is simply this. As she was growing up and learning how to move, her body develops based on how all the pieces move together. And so compensation or functional, whatever you want to call it, it just develops that way. And so in athletes, especially weekend warriors or otherwise, they've been moving the way their bodies move for whatever reason over the last 20, 30, 50 years, whatever it is. They get to someone like us where we start undoing some stuff, peeling it back like an onion. We start finding all these little problems here, scar tissue in this, and inefficiency in this muscle group or that system or what have you. We find those and we start fixing them for what they came in for. Right? They're paying us, like she's paying us, or him, Dr. J, to fix the knee. We, by the nature of what we do, want to get the hips and everything else kind of fixed because we know that's part of the problem. From there, we're not trying to sell them on, hey, let me fix everything in your body. But what we tell them is don't be surprised if when you go back to sport, months down the road, you start noticing something else popping up. And it's only because the input we now have as an athlete functionally is different than it was a year ago, which means the rest of the body has to recalibrate to this new input. And it doesn't matter what sport you're in. But you get a golfer who all of a sudden their hips open up 20 degrees or hitting the ball further. Well, that 20 degrees of torque has to be slowed down when they hit the ball. Slowing down the athlete, like I mentioned with the volleyball player, jumping isn't the problem, it's landing. Whenever you're trying to slow down a moving machine like that, that's not easy. And you got a rotation, or with volleyball's unique is you're jumping, you're in the air, and then you're creating torque. You lose some of the foundation that a golfer has where you have all of your basically gravity-based lower body muscles to help slow you down. You've got your upper body. So with that, you're like, she's got to get stronger in other areas now because she has to be able to handle the more torque and power she's generating because when she leaves the floor, she's adding 20% power up in that arm. So that's different. So when that happens, that's why you get these other things that pop up. Yeah. And I mean, I want to talk about, you can't tell how excited I am. That's what makes our job fun.
Yeah.
You know, it's not to say, oh, she's going to be hurt again or somebody's going to be hurt again. It's like, no. We're just halfway getting you back to being a 100% amazing beast of an athlete. And that's what our goal is. So that's the explanation under why.
And part of her blood flow restriction workouts was like it's 3 lower body and 3 upper body just to kind of give the body time to recover. Doing shoulder presses, let's get it overhead. Lat pull downs, get the shoulder in a good position, get the back involved, and that sort of stuff. Because now she has that more motion.
Yeah. Yeah. You got to, the way it's verbalized online, you're basically creating a new system of movement then you're trying to stabilize it, and then you're trying to strengthen it.
Yeah.
And in those processes, like things pop up or whatever, you get plateaus because there's new input for the body. Most of our clients, since we are enablers, are going to be, doing their sport or kind of, checking it out. Or, hey, this weekend I just went and, hit 60 balls just to see, or I just went and practice, for half practice to see how it is. They always want to test because they want to get back out there. So that's why you have those ebbs and flows, ups and downs, and so forth. And then what he was doing was great because he's really trying that BFR process. He was trying to connect those dots for her. And so now I honestly reach out in a few weeks. I just say, how's the knee? How's the shoulder? How you doing?
Oh, yeah.
That's just one of those things. I'd love to hear back from that and see where they're at because it's fun for us to see how our client athlete. I like client athlete. Anyway, how they're doing in the future moving forward.
Absolutely.
So, yeah. All right. Well, we've tired this thing out. We have nutrition still to cover with children.
Yeah.
And
That
then-
one's fun.
That's going to be a long one. I'm just kidding. It's not going to be that long. But we'll go into that a little bit. We'll talk about how to help the scheduling, some ideas, strategies basically on how you can kind of manipulate those things. It's not easy. I'm not going to lie. But it's something that if you can, commit to and reorganize your habits on a day-to-day basis, you can make a big change.
Absolutely.
So, all right, guys. Well, I'm Doc T.
Dr. J.
Dr. David.
See you guys next time.